So I'm going to talk to you about what I feel are practice-changing papers. So this was presented at ASCO, the Cancer Intervention and Surveillance Modeling Network, to see over the last decade, have we really made a difference to the care for our patients? It was based on 6 simulation models of the Cancer Intervention and Surveillance Modeling Network. And as you can see, there has been a difference we've made both for ER positive, HER2 negative, triple negative as well. But the maximum improvement has been in those patients who were ER positive and HER2 positive, about 2.5 years. And if you look at the mortality reduction in the paper that was presented, there was a 59% reduction in mortality overall over the last decade. And they've also tried to tease it down as to what has made the difference. And as you can see, that the screening has made a difference. The improvements in early stage treatment have definitely made a difference, so I will focus on that area. And also the metastatic treatments, I'll focus on a couple of studies as well because of paucity of time. So coming on to HER2 positive breast cancer, I think what we want to do in HER2 positive is de-escalate in low risk and escalate in high risk, and also to choose the optimal endocrine therapy for these patients. So for low risk, we want to see whether we can reduce the chemotherapy. The APT trial, I think, is the only phase 2 study which has been practice changing with a disease-free survival of more than 98%. So this study, the ATTEMPT trial, looked at de-escalating for patients with stage 1 HER2 positive patients, and they compared it to the TDM1 was compared to the APT regimen, almost 500 patients, and you can see that the curves are on top of each other, and the benefit is there for those patients who had tumors which were less than 1 centimeter and more than 1 centimeter. We know that in APT trial, the tumors were up to 3 centimeter as well, but majority of the patients, it was actually less than 2 centimeter. So I think all of us are fairly comfortable for patients up to 2 centimeter ER positive, node negative, to actually go for just weekly paclitaxel times 12. So now TDM1 also is a very good option. The patient-reported outcome measures showed that TDM1 led to less neuropathy, and it may be acceptable for patients who are concerned about neuropathy and alopecia, but it comes with a huge financial toxicity, but we are lucky to have a biosimilar in India as well. So de-escalating duration of adjuvant trastuzumab, the individual patient meta-analysis of 5 non-inferiority randomized controlled trials. I think Persephone was a very beautifully run study by Helena Earle. The results were presented, and I was very disappointed when it was felt that it is not practice-changing globally. And I was very pleased to see Seema publish this paper in JAMA a couple of years ago, where she also did this analysis of these trials, and Helena also presented this at ESMO last year. And both of these very beautifully run meta-analysis show that 6 months is non-inferior compared to 12 months. Yes, we know that 9 weeks versus 12-month non-inferiority has not been confirmed. There is not only reduced cardiotoxicity, there's reduced financial toxicity, and it does reduce demand on healthcare services, especially for those services which have universal health coverage like UK, Canada, Australia, and other places as well. I think this should lead to guideline changes so that we are able to empower the patients to make a choice at 6 months whether they really want to continue to 12 months or not. And I strongly feel that we should do it in every single patient. So the SHORT-HER study actually looked at, it was a trial which looked at 9 weeks versus 12 months of trastuzumab. Almost 1,300 patients were included. But this study, again, very eloquent, looked at the impact of optimal endocrine therapy in those patients who were ER positive and HER2 positive. 40% of these patients were premenopausal. They classified them into 3 groups, aromatase inhibitor versus tamoxifen aromatase inhibitor. They should have had tamoxifen or an AI for at least 1 year versus tamoxifen plus or minus the GnRH analogs. And this study showed that the use of aromatase inhibitor was an independent prognostic factor in the multivariate analysis, and it led to a significantly better disease-free survival if you gave these patients. So I think we should, in clinical practice, which is very easily doable, think about it both for our premenopausal patients and postmenopausal patients to fit in an AI in their treatment regimen. And also for patients who, in premenopausal patients, the ladies who had a GnRH analog, the progression-free survival looked better, the curves slightly better, but not significantly better. So there's potential benefit of ovarian suppression. Coming on to ER-positive early breast cancer. So again, we want to look at whether we can define very low-risk patients and maybe de-escalate treatment, especially in the elderly, whether we can omit radiation in some select patients. In high-risk patients, can we do something to improve their survival, add adjuvant CDK4/6 inhibitor, and also what is the optimal duration of endocrine treatment? I'll just discuss a few studies. The adjuvant CDK4/6, I won't go into the details, but the 3 pivotal trials, PALLAS, PENELOPE-B, which were the palbociclib trials, and the MONARCH-E trial was the abemaciclib trial. The PALLAS and the PENELOPE-B were negative, and the MONARCH-E trial was positive. And actually, it led to the approval of abemaciclib by FDA and EMEA. The approvals are different. The FDA has approved abemaciclib for patients, those who have a Ki-67 of more than 20%, as per the cohort 1 criteria, more than 4 nodes involved or tumor size more than 5 centimeter, grade 3, 1 to 3 lymph nodes. And the EMEA does not have a boundary of Ki-67. They've improved it blanket in high-risk patients. So why were there these differences in these studies? Was it scheduling? The palbo was given for 1 year, and abemaciclib was given continuously for 2 years. And PALLAS, the palbo was given for 2 years, but was given intermittently, like we give for 21 days or for 28-day cycle. There is a short follow-up for an adjuvant trial, and I would urge you to read this paper, which was published in eCancer a few weeks ago by Amola Khade and Vishal Gayawali. So where they actually tease out why it was maybe premature for the FDA to approve abemaciclib in patients with early breast cancer with a short follow-up. And I think there is, again, a huge financial toxicity involved for our patients as well, and a toxicity related to the drug as well. It's not an easy drug to take for 2 years. Coming on to the duration of adjuvant AI therapy in postmenopausal women with ER-positive breast cancer. So this study looked at those patients who'd had 5 years of adjuvant endocrine therapy. Whether extending it by another 2 years or 5 years, does it make a difference? We know that AI is quite toxic for our patients, whether they are premenopausal or postmenopausal. So what this study very nicely showed that the curves are literally on top of each other for disease-free survival and overall survival. But there is an increased risk of bone fractures for those ladies who were taking 5 years of extended adjuvant AI therapy. So this was also endorsed by another study, which was an Italian study where patients had received adjuvant tamoxifen for at least 2 years. They were randomized to 2 years versus 5 years of letrozole. And they also showed that patients who received 2 to 3 years of tamoxifen extended treatment with 5 years of letrozole had an improvement in disease-free survival compared with 2 to 3 years. So I think one can safely say that we should consider adjuvant aromatase inhibitor therapy for at least 5 to 7 years. And when patients reach to 5 years, I mean, this is a part of the ESMO guidelines, and I think we're coming up with the ISMPO guidelines as well under the ISMPO leadership, that extended therapy for another additional 2 to 3 years is something that we should consider for these patients. Coming on to whether we can de-escalate in patients who are more than 70 years of age, whether this was, again, a wonderful study. Huge congratulations to the investigators, because I know I was trying to recruit patients to the ACTION trial when I was in UK, and we just were not able to recruit, and we had to close the study. So again, patients who are more than 70 years of age, based on the genomic grade index, which is a 97 gene signature, They also looked at, stratified the patients by the G8 score, by the Charlton Comorbidity Index, and the 4-year mortality Lee score. Again, a beautifully done study. Patients with high GGI were randomized to endocrine therapy versus chemotherapy and endocrine therapy. This was done in French and Belgian centers. The chemotherapy given was ACTC versus, and also they allowed liposomal doxorubicin cyclophosphamide as well, and showed that the high GGI actually does not predict for an overall survival benefit with addition of chemotherapy. So maybe one can safely omit chemotherapy in these patients. But again, GGI is not a commonly used biomarker, so I'm not sure how extrapolable this is. There is no talk about benefit of adjuvant targeted treatment and bisphosphonates as well. Can we omit adjuvant radiotherapy in a select group of patients? Again, this is in patients' Lumina trial, T1N0 ERPR positive, Ki67 less than 13%. Again, very difficult to see how they chose this criteria. Patients who'd had breast-conserving surgery and were more than 55 years of age, they excluded multifocal, extensive DCIS, and LVI, which we know is a surrogate of nodal positivity. And the trial was positive in that it met its the pre-specified boundary of 5 years overall survival of 97%, and the local recurrence rate was 2.3%. The boundary was that of 5%. So is this practice changing? I think we know that the CALGB trial and other trials have shown that the effect of radiotherapy can be seen beyond 5 years as well. So I think we need to wait for more data. We need to wait for longer follow-up. I think if this was a drug, the FDA would have approved it immediately. So I think because we are investigators and we think rationally, it needs further validation. Clinical, pathological, molecular. So I think we need to wait for a few more years. Looking at Ki67, can we really use it? This working group was published last year. Between the pathologists, there is an issue about of 5 to 30%. We know that. There is a disagreement on the best scoring method. So I'm not sure whether there is any clinical utility of Ki67 IHC. The group has actually said that Ki67 5% or less, 30% of more can be used to estimate prognosis, but cannot be used to guide treatment decision making. Denosumab, again, the long-term follow-up, I think it's very, very important that we focus on the long-term follow-up of these trials. The ABCSG study, we know, randomized patients to 60 milligrams of denosumab twice a year for 5 years. Primary endpoint was time to first clinical fracture. So the long-term follow-up after 8 years presented at ASCO this year did show that there were significantly fewer fractures. It met its primary endpoint. But survival with denosumab at 8 years was 26% versus 19%. The reason why we've not adopted it is because it conflicts with the findings of DCARE study, which were negative, and which specifically looked at disease-related outcomes only, which this study did not look at. The guidelines, even today for us, we give zoledronic acid, bisphosphonate for 3 years. Maybe I think safely this could be an option for those with renal dysfunction or poor venous access. Triple-negative breast cancer, I think all of us have talked about a lot about that. It does lead to increased PAT-CR rates, which we know about, and about almost 13 to 20%. The updated results of Keynote 522 were presented at the virtual plenary, which showed that there is a meaningful benefit in event-free survival. And the results of JEPAR-NUVO, also at a follow-up of almost 42 months, showed that there's a 3-year invasive disease-free survival of almost 85% with durvalumab versus 77% with placebo. So almost a significant reduction in invasive disease-free survival. One must not forget that there are toxicities with IO in neoadjuvant setting remain a huge concern. I mean, I've had 2 patients over the last year with severe hepatitis, then leading on to high dose of steroids, leading on to pneumocystis pneumonia. Another patient with sick sinus syndrome admitted in CCU with bradycardia, hypotension. So I think we must not forget that, these are toxicities which can be life-threatening for the patients. So that adequate counseling for our patients is very, very important. Yes, it is practice changing. It can be incorporated into the neoadjuvant paradigm with anthracycline and platinum, because the Keynote 522 did use platinum. That is another discussion whether we should use platinum in neoadjuvant and adjuvant setting. In triple negative, I tend to use it in all my patients. What is less clear is what we do in adjuvant setting after pathological complete response. So in patients with stage 2 to 3, I did an online meeting yesterday, and again spoke to quite a few of my colleagues, because again, we are not very clear in patients who carry this germline BRCA mutation. What do we do when they've had a path-CR? So I think this is a nice summary. There are those who have stage 2 to 3 and who receive neoadjuvant pembrolizumab. If they have a path-CR, they've had an amazing response, maybe it's reasonable to continue adjuvant treatment if there is no significant immune-related toxicity. But if there is a non-path-CR, and if they have a germline BRCA mutation, and I think Shona is going to talk about it in more detail later on, so adjuvant olaparib is, I think, should be considered. An addition of pembro may be considered, and again, in this ESMO Young Women with Breast Cancer group, everybody had a different opinion on this. So in non-germline BRCA, adjuvant pembro with CAPE is what is recommended. Decisions about combining CAPE, olaparib, pembro, of course, huge financial toxicity, but toxicity of the drug also is there, which one should not discount. But we also know that the risk of recurrence is very high in these patients, so whether you would want to justify that. Advanced breast cancer, I'm not going to spend too much time on, but I just loved seeing this study, which was published by Dr. Gupta from Tata Hospital. Almost 15 centers from India took part in this ENCLOSE study, which is a fixed dose combination. They did it in 2 phases, phase 1 and phase 2 of capecitabine and cyclophosphamide. In patients with metastatic breast cancer, this was a phase 3 study. Multi-dose very beautifully pharmacokinetics was done. And the part 2 looked at the efficacy of this combination. And as you can see, the results are absolutely fantastic. And it is safe to say that the fixed dose combination of capecitabine at 1800 milligrams per day and cyclo 80 milligrams per day is effective, and was well tolerated in those patients who'd previously been treated with an anthracycline and a taxane combination. So this is metronomic type chemotherapy, which is, I think, very, very important, not only for us in India, but also globally as well. I feel that this should be practice changing. Safety profile is good. It reduces the pill burden. It avoids IV access to the patients. And for patients' quality of life, I think it'll be good to see what the patient-reported outcome measures are from this study. 2 studies briefly, I would like to just mention the TROPICS trial, because it has been practice changing. Randomized phase 3 patients who've been previously heavily pretreated with ER positive, HER2 negative breast cancer, randomized to sacituzumab, govitecan, and treatment of physician choice. There's a significant improvement in progression-free survival in third line and beyond. I think it's the data looks promising. But again, it comes with a huge financial toxicity. None of these studies have actually looked in detail about patient-reported outcome measures and financial toxicity. The HER2 positive patients, we are clear about first-line TPH, the Cleopatra trial, Emilia, TDM1, second line, and third line with the Destiny Breast01 study. We are also clear that trastuzumab deruxtecan also showed very good activity in third line setting. So I think this press release came out. The phase 2 data has been kind of endorsed by the phase 3 data that Enhertu significantly delayed disease progression in the Destiny Breast02 study, which hopefully will be presented next week at ESMO. This was the press release. So it's nice to see that the phase 2 data has been proven to be positive in phase 3 as well. So the Destiny Breast 03 study is in patients with HER2-positive patients previously treated with trastuzumab tax. I think I will basically talk about, this is a positive study. And basically, HER2-low, very briefly, this is something which we need to think about in our patients and look at score of 1+ or IHC 2+, the Destiny Breast 04. So trastuzumab deruxtecan is a drug I think has shown to be promising in both HER2-low and HER2-positive breast cancer. And the only concern I have is, of course, the financial toxicity and also the interstitial lung disease, which we are learning more about. And I think it's very important that that if we are using it, we are very well aware of this toxicity, which can be in the range of 8 to 12%. So benefit, again, observed in all patient subgroups, including IHC scores, regardless of CDK4/6 inhibitor use. The ASCO, this led to an ASCO rapid guideline update as well. So I was part of this ESMO breast cancer in young women group. The guidelines have been published. So I would urge you to read this paper. Most of the recommendations I've discussed apply to younger women as well. The only thing I wanted to point out is 5 years of tamoxifen 20 milligram does reduce the risk of breast cancer as pharmacoprevention for women with an elevated breast cancer risk by various models or who carry the germline BRCA mutation. And of course, use of GnRH should be offered to all patients to reduce the risk of premature ovarian insufficiency and also possibly preserve ovarian function. That is for women less than 40 years of age. I think this is my last slide. We have to look what the magnitude of clinical benefit is in our patients. For our patients, only two things matter. Will I live longer? Will I have good quality of life? And of course, for us, cost is a huge, huge factor, and which must be into the treatment mix when we are discussing it with the patients, along with all the other stuff that is there. Thank you.